He was asymptomatic, active for years, jogging, golfing. He had some PAF and then had a permanent pacemaker placed in 2016. In the last 2 years, he's had very progressive shortness of breath, really bad shortness of breath. Here's this very active guy who now can't do anything. He had, of course, a coronary angiogram. That's the first thing that was done, and have a stent of a circumflex, but that didn't do anything. Then they actually saw that he had mitral valve disease and severe pulmonary hypertension. I mean, this is severe pulmonary hypertension. So they put him on sildenafil, and it made him worse. Okay, so this is the background that you have. He puts himself at about 40% of his functional capacity, can't do what he wants, poor quality of life, and he comes to you for further evaluation. Here's the exam. You want to say anything about the exam?
Well, okay, so JVP, so he's obviously got an elevated JVP, decreased breath sounds, and then he's obviously got RV problems with the pulmonary hypertension. I mean, it fits. He's got the loud P2.
Yeah.
And he's probably got PR, I imagine.
It's kind of a rumble. It's apex.
Oh, okay. So it may be that he's got, it's at the apex, so he may have mitral stenosis.
Yeah, and that P2 was really, really loud. You could hear it all the way at the apex. Here's his electrocardiogram.
And actually, I should correct myself, because if it was PR, it would have started at P2. Sorry about that.
Okay, here's your echo. This is the squashed LV.
We forgot to mention, for those of you that haven't been here before, Nish has labeled the ventricles there, but the Mayo format is we put the left ventricle on the left, and we'll try to be careful through the course to point out which ventricles which to you as we show images.
Yeah, so that means the color we're looking at is the regurgitation, which has a very, very high velocity. So there's severe pulmonary RV systolic pressure overload. Okay? This is interesting, and we'll talk about this a little bit later, but a lot of times you might not be able to get a good TR signal, and the PR signal and the RV outflow are very, very good measures that this is indeed severe pulmonary hypertension. And this is one of the pre-questions that you filled in that we'll go over at the very end. But the end diastolic velocity of the PR is very elevated. It tells you that the pulmonary diastolic pressure is elevated, and you see that very early peak in that double outflow in the RV. That means that there's severe pulmonary vascular disease here.
So we did have PR, and you just missed it on the exam?
Yeah. Okay, so here's where the meat is. The transmitral gradient is shown at the bottom right there. The gradient's 22 millimeter of mercury at a heart rate of about 60, and the PA systolic pressure is 90. Okay, that's bad. That's why he's so symptomatic. Okay, what are we going to do? Open mitral valve replacement, percutaneous mitral balloon valvotomy, percutaneous mitral valve replacement, aggressive pulmonary hypertension therapy, or nothing. Hartzell, what's the risk of open heart surgery?
Well, it's hard to say. I would say for an 80-year-old with advanced mitral disease, it's maybe 3% or 4% or 5%, but it depends on the etiology of the disease. I just go back to the EKG. I think there is something abnormal in EKG, or not unusual in EKG. The fact the guy's still in sinus rhythm.
Yeah.
And he has a reason to be short of breath with a large right pleural effusion, but sometimes we'll see patients with severe mitral stenosis. They say they get along fairly well, although if you question them carefully, they're limited. But they're compensated until they go into atrial fibrillation. As soon as they go into atrial fibrillation, they feel awful, and I suspect that was in this guy's future as well.
Yeah, this was thought to be a rheumatic mitral valve, not one of the heavily calcified mitral annuli, because the commissures were down, so on and so forth. 3 to 4%, you would risk, Hartzell?
I think something in that neighborhood. Again, it depends on the the patient, how they look, their creatinine, that sort of thing?
Yeah, creatinine was good. I mean, the guy was out golfing 2 years ago. Buzz, comments?
Yeah, I was just going to, there is a population of patients, particularly males, that present with mitral stenosis, present as pulmonary hypertension, and theoretically their low output from the pulmonary hypertension kind of protects their lungs so they don't always have the orthopnea, PND, hemoptysis that other patients would have with this degree of mitral stenosis.
So we don't see this anymore. This is critical mitral stenosis with severe pulmonary hypertension. And actually, this very intelligent anesthesiologist was worked up at home, and the surgeon said, I can't operate on you because you got a 30 to 50% operative risk mortality because of your pulmonary hypertension. Okay. I mean, the PA pressure was near systemic. The PA was about 90, and his arterial pressure was about 90 to 100. So that's the information he was given. And because of that, they actually tried to do a mitral balloon valvotomy at home. They got across, and they blew. Fortunately, they didn't make them worse, but they didn't make them better because that valve's so heavily calcified. So Hartzell, your comment on that? I mean, critical mitral stenosis, does it matter to you if the pulmonary hypertension is reversible at the cath lab?
Well, I suppose in a rare patient it would matter. I mean, it is possible to have two diseases, but, you know, with severe pulmonary hypertension for some other cause. But almost always, if you have left-sided disease and severe pulmonary hypertension, if you fix the left-sided disease and can get them through the perioperative period, they'll do well. So I would say we don't pay, I mean, we pay attention to it, but I can't remember turning down a patient because of PA pressure, either with mitral valve disease or hypertrophic cardiomyopathy or aortic stenosis. We don't think that that's that much of a risk factor.
Yeah.
The business about RV function is interesting because if you have severe pulmonary hypertension, you're judging right ventricular performance by ejection fraction. That's like measuring ejection fraction with severe hypertension. It's never going to look good. So I don't pay that much attention to the RV systolic function if they have severe pulmonary hypertension.
Yeah, so for those of you who work in the cath lab, you know, we get asked about this reversibility of pulmonary hypertension, and, you know, we usually use nitric oxide. But if we have a patient whose left atrial pressure is 35 with severe pulmonary hypertension, we give them nitric oxide, we're going to put them into really bad pulmonary edema because you're actually opening up those kind of protective vasoconstriction there. You can try to use nitroprusside, but the systolic pressure was 90 millimeter of mercury of his aortic, so there wasn't a lot of room to work. But your point is very good. The question is that pulmonary hypertension reversible? That's the major question. The other thing that was being considered is because he was thought to be at a 30 to 50% risk of surgery is some of these percutaneous devices that everybody's looking at. But in a patient with mitral stenosis, what they actually do is they do these reconstructions. And most of the time, the size of these percutaneous valves in that small ventricle would result in outflow tract obstruction. So in the mitral stenosis patient with the small ventricle, even the percutaneous options that are getting better and better and better probably won't be possible. So the trick from my standpoint is get your best surgeon, sitting right here, and go for mitral valve replacement. And the reason is because we do have some old data that with mitral stenosis, and this is the percutaneous mitral valvuloplasty data, that if you got severe pulmonary hypertension and you immediately fix the mitral stenosis, about a third of the pulmonary hypertension will recede. And then 6 months later, another third of the pulmonary hypertension will recede because you've got some remodeling of the pulmonary vasculature. So I think Hartzell's point is correct that if your left atrial pressure is elevated and you can lower your left atrial pressure, it's well worth to try, irrespective of the severity of the pulmonary hypertension. But I echo your worry. Now, he was in the hospital for like 2.5 months. I didn't know if he was going to make it, but this guy, he really pulled through. And you know, here's his chest X-ray afterwards. And take a look at the squashed left ventricle on the left side, and the big RV on the right side, and what happens a few months later. And this talks about that right ventricle recovering that you pointed out, which is very, very good. So I think the take-home point is that we don't see mitral stenosis much anymore, but when we see critical mitral stenosis with severe pulmonary hypertension, it's really never too late to intervene because, number one, the left ventricle is protected. It's unlike some of the regurgitant lesions. And then number two is you have to get your best surgeon possible, so we hope that the staff never retires.